Well, very good Wednesday morning to you. Thank you so much for joining our Facebook Live discussion with GBMC. I'm Megan Knight, anchor of Good Morning Maryland, and I am joined this morning by Dr. Jason Nellis. He is the assistant professor of facial, plastic, and reconstruction surgery at the Randolph B. Capone Cleft Lip and Palate program at GBMC. That's a mouthful there, but good morning, Dr. Nellis. Thank you so much for joining us.
Yeah, good morning. Thanks for having me.
All right, so we are talking about cleft lip and palates. So before we get into that, maybe if you want to just give us a little quick background about you and what you do at GBMC with the cleft lip and palate program.
Yeah, so I'm a part of a big team that cares for children who are born with cleft lip and palate, as well as other congenital facial deformities. And so the role I play is I'm one of the surgeons, so from the surgical side and helping repair cleft lips, cleft palates, as well as pretty much any other issues that children have. But beyond just myself, we also have a team that involves social work, dentistry, oral maxillofacial surgery, as well as swallowing therapists and otolaryngologists who help sort of treat the ears, as all these different issues need to be addressed over time. And in a way, we sort of, from the day these kids are born until they're adults, they interact with everyone in our team, and we all sort of work together to help provide comprehensive care for the kids.
That's fantastic. And just a reminder, if you're watching our Facebook Live discussion, you have any questions at any point for Dr. Nellis. Again, we are talking about cleft lip and palate today. So if you have a question, please leave it in the comment section, and we will make sure that we ask Dr. Nellis during this discussion. Okay, well, I guess first easy question for you, Dr. Nellis, is what does it mean to have a cleft lip or palate?
Yeah, so there are two distinct facial deformities. So for a cleft lip, essentially it's cleft within the lip. It can sometimes be on one side, sometimes both sides. Oftentimes it can extend into the gum line, essentially where our teeth fit. And in certain cases, you can both have a cleft lip and a cleft palate. The palate is where, if you think about the roof of your mouth, the roof of the mouth when you were just an embryo and growing inside mother, they just didn't completely fuse together. And that results in a communication between the nose and the mouth. And as you can imagine, that can have issues, not just with appearance, but also with feeding, where, in other words, if you're trying to eat by mouth and then you have food or fluid or milk coming through your nose, that could be an issue, but also with speech. So our palate is along with our tongue and, the overall shape of our mouth and our nose, sort of as air comes out when we try to speak, all of those are interconnected, and they actually function in a very coordinated fashion, so that if you have any deficiency or abnormality, that can affect your ability to speak and communicate. And so in sort of understanding from, embryologically all the way through as they grow and progress, it's really important to sort of understand those things to sort of help figure out how can we best address those and let kids live sort of a normal life.
Absolutely. So when do parents typically learn or maybe notice that their children might have a cleft lip, palate, or both?
Yeah, most commonly, at least in the United States, once the child is born, either the pediatrician, a cleft lip is a little bit easier to recognize right away, but usually the pediatrician will look inside the mouth, whether, right after they were born or when they go for their first visit afterwards. But sometimes it's the nurses. The nurses will notice that there's a cleft, and they'll, let the parents know, but also contact, our team and let us know. But and actually what we're seeing more frequently is because they're doing ultrasound ahead of time, the prenatal ultrasound. We've even had some families that they had an ultrasound that identified a cleft lip, and we actually met the parents before the child was even born. And that was pretty neat because we sort of got to talk about them and help prepare for what's to come. And I think that provided a lot of reassurance for everyone, and it was nice for them to meet the whole team. And then once the child was born, we just, we did the repair for the cleft lip when they were about 3 months old. And things have evolved. As technology gets better, we're identified sooner and sooner, but usually right away after they're born in the hospital.
Okay. Yeah, wow, that's incredible that you can see that even before the baby is born. I'm sure, like you mentioned, that's just probably one less thing that mom and dad have to kind of worry about or, get stressed over when the baby is born. They already know that that's happening, so they can take care of it as soon as their child is born. That's pretty neat. So you said 3 months. How young is it that you can do these surgeries or treatments to fix the cleft lip or palate?
That's a really good and common question. So for cleft lip specifically, we do it at around age 3 month. And the reason why that is we want the child to feed and grow and, in other words, be healthy enough to sustain the surgery. Now for cleft palate, we end up waiting until a little bit later, usually anywhere from 9 to 13 months. More commonly, we do it at about a year. And the reason is you're sort of balancing sort of the speech and the mid-face growth. In other words, if you do it earlier, you get better speech outcomes because, kids start talking after about a year. And but if you do surgery, then you're balancing also, well, like how does it affect growth later on? And so the year turns out to be good. But those aren't just the only surgeries that these kids often need. The teeth becomes a role. If they have a little cleft in their gum line that communicates to the nose later in life, around age 7, 8, 9, they end up getting a bone graft to fill that in. And then even later, just yesterday, I had a nice young adult. She had a cleft lip and palate that was repaired and had done excellent. She's the sweetest girl. And she had a little bit of a deformity from the nose, which is associated with cleft lips. And we did a rhinoplasty for her. So we improved the nasal breathing as well as the appearance of her nose. And so in a way, it's sort of a stepwise approach. And that's why we have a big team, is because for each of those steps, they have the person who's well equipped and with a lot of experience. And we always talk about all these different steps along the way with the parents, right when they're born, so that there's nothing that's a surprise. And yeah.
Very good. All right. Well, yeah, maybe just walk us through then if you notice or a nurse or a doctor notices that your child does have a cleft lip or palate, they come to you all there at GBMC. So kind of walk us through that process of what happens the moment the first meeting that they have with the team.
Yeah, sure. So, once the cleft is identified, usually what will happen is either the nurses will notify the pediatrician. We also have a geneticist on our team too. She often knows about these patients early on. And then the next step is getting a visit with our cleft team. So every month we get all these providers in one clinic. It's, the Randy Capone Cleft Clinic at GBMC. And essentially mom with baby will come in the room, and each of the experts in their own domain will come in and talk to them about answering questions. And then the rest of our team will sort of help plan, when there's going to be surgery and what other care needs to be provided. They'll start working with swallowing. So early on, our speech language and swallow therapists will work with parents on everything from bottle feeding, how can they improve how much nutrition the newborn is getting. And so it's also a lot of communication, not just in that clinic, but also outside of clinic. And our team leader, Steph, she's awesome in making sure that, because as you can imagine, you're coordinating a lot of different providers. So she sort of spearheads in making sure that the kids are getting what they need when they need it, and that any questions that come up from parents, that they're getting answered or getting directed to, like if they have questions on surgery, we'll either have them come in or I'll talk to them on the phone, or before surgery, they'll come to my clinic and we'll chat further about what's involved and what to expect. And then we go from there.
Very good. And then, of course, follow up even after the surgery, or I suppose maybe there can even be multiple surgeries with the treatment of this, correct?
Yeah, no, that's correct. So for the cleft lip, we put little sutures in, and so they usually come back a week later and we take out those sutures. And then a lot of the care for the scar, as you can imagine, is afterwards. So making sure it stays nice and moist with ointment. Then afterwards, we recommend using like a silicone-based gel sort of help improve the appearance. There's always a small chance that you need to make a little fine-tune adjustments to it, usually about 10 to 15% or less. So if they need that, then that would require a second surgery. But majority of the patients after a cleft lip repair are pretty good, and they don't need any further surgery. And then for the cleft palate, they started eating right away, and they work again with our swallowing therapist with that, and also working with speech therapy to get their speech as they start becoming older. And yeah.
Okay. And I imagine too, I mean, you like you were mentioning earlier, talking about doing these surgeries as young as 3 months. I would imagine then that catching this as early as possible is better for the outcome for your child. But say, you end up not dealing with it or maybe noticing it so much a couple of years down the road. Does that mean it's going to take longer, or is there still hope for parents, even if maybe they've waited a little longer to get this diagnosis and get the treatment started?
Yeah, in a way, it's never too late. In other words, even if it's identified really late, you can still come in and see us, and we'll do what we can to help improve the cleft. Actually, I do a lot of mission work abroad, and I've seen even adults coming in with cleft lips that were never repaired, and we can still repair it. But that being said, in terms of identifying it earlier, the advantage is when you're developing speech early on, between age 1 and 2. The earlier we can sort of set that up for success, the better. Now, the other thing is also for growth. If there's any issues with nutrition, you can essentially have sort of unoptimal growth. And so that's why also working with teams to make sure the nutrition is on board, it will help improve the outcomes from a nutrition standpoint. And then, with swallow as well, working with our team members with that earlier is advantageous. So while yes, in the best case scenario, it's better to identify it early so that way you can get plugged in and get the care that you need. If it's identified later, we can still help the kids out.
There is still hope, so parents don't have to worry as much, which is good news. So there at the Randolph Capone Cleft Lip and Palate program, I mean, maybe just talk to me a little bit about what you think makes that program so unique. It sounds like you've got a wonderful team there set up for parents when they come into you, but if you want to just give a little shout out to some of the other unique parts of the program.
Yeah, so I think the leadership. So the program was started by Dr. Patrick Byrne, and as well as Dr. John Kakameze. Steph, who's our team leader, is awesome. I think really what sets the team apart is I'd like to say beyond just the surgery itself, is just really like the rest of the team in terms of their responsiveness. Passion, I would say, is the key word. Everyone's really passionate about these kids. We organize events for the kid because, like I said, when they're born, we're part of their family for really the rest of their life. And so we set up events like rock climbing events with the kids and going to the park, and because we also have the different patients sort of interact with each other because they're going through similar life experience. And so as they grow up, they sort of, I have a friend who sort of went through a similar thing that I did. And I think those sort of, less clinical things, I think makes a big difference too. So it's really a community. And I think the whole team is really passionate about setting up that community and making it a place that families feel comfortable and that they're being taken care of. And so while the surgery is important and that's sort of, my domain, but I think everything else is sort of the in-betweens that really, I think, sets the experience to be unique. And, we hope that, the families feel that they're really getting great care, but also joining a community that will help them with whatever struggles they face going forward.
Yeah, just having that community and having that support, I would imagine, is pretty vital in this whole process. And these kids, especially, not feeling like they're alone or that they're different. This is something that happens, and you guys there at GBMC are there to help take care of it and have them lead as normal of a life as they possibly can.
Exactly. Yeah. It's pretty amazing to see, as these kids grow up, some of the wonderful things they do. And, our goal, we would just want them to be a normal kid and play and have a normal life. And so that's sort of the way we approach things.
That's awesome. All right. Well, Dr. Nellis, what's the best way to reach out if there's a parent watching, or maybe they know somebody who's going through this and they'd like to get some more information about the program there at GBMC? What's the best way to reach out?
Yeah, so everyone has their pocket supercomputer, and so going to www.gbmc.org/cleft, we have contact information there, and they'll get in contact with Steph, and she'll help coordinate getting to our clinic. For my patients, I always give out my cell phone. So once we meet, they can give me a call if they have any questions. But yeah.
Very good. All right, Dr. Nellis, thank you so much for joining us on today's Facebook Live. And we're going to be posting this on our Facebook page. So if you missed any portion of it, you can go back and watch and, of course, share with all your family and friends. So Dr. Nellis, once again, thank you so much for joining us.
Thanks, Megan. Thanks for having me.